Suman. Nice to see you.
Morning. Morning.
Morning.
Good to see you.
Suman, do you want to lead it or would you want me to lead this morning? I think it might be you or Elaine last week. I'm happy to lead this morning.
Yeah, I think I did it last week, but I don't mind doing it. And then moving into Wednesday morning, we've got HSE social prescribing.
In recent years, Northern Ireland has become a go-to destination for filmmakers from across the world. With backdrops of rolling hills, dramatic Game of Thrones coastlines and castles, patchwork green fields, and historical cities with their vibrant music, arts and culture. Yet, not so long ago, the world identified Northern Ireland with the Troubles. Health and social care have not been immune from these influences.
There are many challenges to delivering healthcare in Northern Ireland. We're a very rural area. We haven't transformed our hospital system as has been recommended in Bangor. And then we have huge problems in general practice with rurality as well. We have problems with not enough specialists, not enough GPs, and not enough time to give our patients.
And today, Northern Ireland sadly lags behind the rest of the UK in terms of health service outcomes, despite the hard work of many. This film celebrates people who have not been overwhelmed by the pressures and challenges in the system.
My name is Max Watson and I'm a palliative care doctor based in Northern Ireland, but I also work across the UK and in South Asia. Project ECHO, at its heart, the extension of community healthcare outcomes, is about collaboratively facing the day-to-day challenges in delivering health, education and social care through online supportive networks who can not only benefit from expert teaching but can co-create better ways of delivering care.
What we do is a video call. We're primary care physicians, nurses, pharmacists. We even have people from different teams ringing in, so acute care at home, our cardiac rehab colleagues. And what we do is we give advice for patients with a known diagnosis of heart failure, where there's either a clinical question because the patient has symptoms that they would like some quick advice for, or there's a patient who historically is on out-of-date medicines, and the primary care teams can get really quick expert advice from us.
Typical ECHO session, an expert, a facilitator, some IT support so we don't waste valuable time, and some admin support, and then across the community experts, people who want to learn to be able to look after their patients close to where they live. I guess you could say that that's a typical sort of ECHO. It all started in the USA in 2003 when a patient with advanced hepatitis C was seen by Dr. Sanjeev Arora.
20 years ago, I started Project ECHO to bring better access to hepatitis C treatment in rural New Mexico. Patients were dying of a disease we knew how to diagnose, treat and cure, but they did not have access to treatment because there were no specialists in these rural areas. Of 28,000 patients with hepatitis C, only 1,500 had been treated, and there was an 8-month wait to see me in my clinic. Many people died unnecessarily because of lack of treatment.
ECHO in Northern Ireland had its origins about 10 years ago. Like many across the UK and around the world, large sections of the Northern Ireland population are rural, where it can be hard to access the care that we would want. The NHS in Northern Ireland quickly recognised the value of the ECHO approach, and since 2015 has been funding its use across a wide range of clinical areas, from prison care to glaucoma, from care home support to community pharmacy.
There is, despite all of our best efforts, a real gap between the primary care setting and then the secondary care team. Communication is difficult between those teams. the transition from patients to primary care out to secondary care is a vulnerable time for them, and we know that they've increased risk of decompensation. And so Max and I met and we started an initial Project Echo for heart failure care out to primary care from here within our own trust. And that's been going now for about 2 years.
So my experience really of Echo in this area is through the virtual heart failure clinic network, which I know Project Echo has been behind in terms of getting that implemented and how to roll that out. So really the virtual heart failure clinic was created as a way for us to refer into a virtual hub.
I have taken over the lead for an Echo, and that Echo is for the Collaborative Forum for Community Pharmacy in Northern Ireland. It is about supporting a culture of all teach, all learn. It is about developing community of practice. It is about bringing people together who wouldn't otherwise be able to get together and communicate and share experience.
There was a presentation on Echo, and I thought this is really interesting. This is starting to connect people in a new way and create space for different thinking. And then I had the opportunity to work with Max and have a look at how would this land in a prison setting. And within our sites then, we wanted to really think across silos. So we incorporated our healthcare staff, all the different multidisciplinary groups within that, but we also asked our prison colleagues, so we had officers and we had governors involved, but also then other agencies, so our addiction service that would come and support, our chaplaincy service, Housing Rights, Bernardo's, different agencies that come in, and also our education service within the prison as well, our Belfast Met.
So it was already quite well established here at that point. My colleagues, Augusto, who you will meet soon, and Angela, they had already made contact with the group and were already involved in about 4 meetings a year with this team of community optometrists where they would collaborate, present, have case discussions, and there was an obvious kind of subset of patients really that I think my colleague had already thought, right, this is a good opportunity here to try and free space in the hospital setting. So she really encouraged me to kind of get involved with Echo, and then as time went by, I am the lead for what we call the ocular hypertension scheme. So essentially it's a group of patients who don't have glaucoma but who would have previously attended the hospital glaucoma service for an annual review.
I saw it as a fantastic opportunity to build capacity, because I mentioned that ophthalmology is very high demand and therefore it struggles with capacity. And I saw in New Mexico that some of the work was transferring the skills closer to the patient's home. So it cut down patient travel, it built capacity, and I thought we could absolutely use the skills, equipment of primary care optometrists to help manage some of the lower risk glaucoma. And we've taken it to the 3rd level of actually embedding Echo into the consultant contract to support them in terms of job planning, continuing with Echo. So and I think it can only get better. I see potential for the macular pathways. I see really good potential to expand the Echo model.
And patients are very supportive of the Echo. You know, our current model of care is that patients need to attend a central hospital in Belfast, and especially in Northern Ireland when you have a large rural community, this is very inconvenient for many people. And the possibility of having care delivered close to home, and that's a must, and we should facilitate that.
So we have led Echo sessions. We do that in the postgraduate domains as in general practice training, and we also use it in undergraduate. We have brought together general practitioners and hospital specialists in lots of domains, for example neurology, where we get our students when they're on clinical placement to bring clinical cases. We bring their knowledge of people who have engaged with the individuals in a clinical setting, and for example me as a GP, as a facilitator, and a neurologist as a specialist. We have modelled, I believe, the affordances of generalist, specialist
and clinician, or future clinician on the ground, and that is right at the core of our undergraduate curriculum, and I hope that it will continue to grow.
The example of Northern Ireland has been an inspiration for others. Across the UK and Ireland, over 62 organisations have been trained in the ECHO model. These organisations, in turn, have run more than 400 ECHO programmes. Currently, there are 122 active ECHO programmes run by 41 organisations across the UK and Ireland, all benefiting frontline healthcare providers and their patients.
So we were first introduced to Project ECHO at the Hospice UK conference. We just earlier this year ran an ECHO for general practice, the primary palliative care ECHO. Into that we had expert colleague GP who has an interest in palliative and end-of-life care, and we had 60 GPs registered in the programme from all over Sheffield, from lots of different places.
And we're currently delivering what's called an integrated care echo, looking at how to prevent unnecessary or unwanted hospital admissions and how to promote safe discharges. So that's a programme that we've currently got ongoing at the moment across South Yorkshire.
ECHO's made a difference for me because on the ICB clinical advisor role, it's helped me to understand what GPs are struggling with, so we can work out what resources we might be able to support them with in future. The process for GPs to access nursing care right in the last few days of life. We had an intensive home nurse, which is a service in Sheffield to help people right at the end of their life. So having local professionals come and speak to GPs was fantastic, because then we all went away with a better understanding of how the local system worked.
It's gratifying to see the spread of ECHO from Northern Ireland to other parts of the UK and beyond. And it's not just the UK. It is wonderful to see ECHO making a difference in other countries.
We first started using ECHO in 2018 under the suggestion of Dr. Max Watson. At that time, we recognized a gap in the paediatric palliative care services available in South Asia, particularly in India, and we decided to start with a program training clinicians in India. We knew there was a huge gap in terms of the knowledge and skills of healthcare providers in the region when it came to palliative care, and we wanted to use our expertise to support colleagues to learn more about this area.
The difference that Project ECHO has made on healthcare in India is phenomenal. Look at my field of palliative care alone. What a huge burden of suffering has been scooped out of the country through the thousands of healthcare providers who have been trained. And imagine similar change happening in preventive, promotive, curative and rehabilitative healthcare.
And in the past few years, we've expanded beyond South Asia into Southeast Asia and into the Eastern Mediterranean region. And we've also been able to mentor colleagues and support them as they develop ECHO programs in the East Africa region, Southern Africa, and Francophone Africa. Overall, directly, we've trained more than 20,000 clinicians, and we've impacted thousands more through our work with partners.
We have a shortage of staff, and we also have huge waiting lists in secondary care, which is impacting on primary care because patients are coming back to us in general practice because they have to wait so long to get their procedures carried out in the hospital.
Our central tenet is the right patient gets the right treatment at the right time. But if I just keep adding those patients to a never-ending waiting list, I'm not doing my nurses a service, nor are we, more importantly, doing the patient a service. So I think this is a way to try and bridge that gap. And since the heart failure we know is increasing, the estimation is it's going to go up by 92% by 2040. I mean, it is coming. We have to work now to try and improve and streamline our services.
So I thought, well, this is an idea that we could actually get people together. We now talk about a community of practice and build that. Because the skills were there, the equipment was there, but what maybe wasn't there was the trust between primary care, secondary care, different expectations on who could do what, who should do what. And I thought, well, if we could get together and have a supportive platform where we all teach, all learn, then we could start to build capacity.
So in Northern Ireland, we benefit from a pharmacy profession that is truly cross-sector. Now, we've really noticed this, I suppose, during COVID, whenever we started to see really large numbers of pharmacists participating in echo sessions where the focus primarily was on information giving at that time. But since then, we've really built on that, and now we have a new collaborative forum for community pharmacy in Northern Ireland and a number of other echo platforms for pharmacy that are really adding a huge amount of value to our development of the workforce, our development of our clinical expertise, and are also very, very highly valued by the profession.
Echo can definitely be part of the solution, because Echo has filled a gap where, especially in education and mandatory training and communication, we haven't got the time anymore. We used to be able to have time to go to meetings and to go to educational meetings and to meet up with our hospital colleagues. None of us have that time anymore because the demand is so vast. So Echo is a great way of allowing us to have some mandatory training in primary care and also in secondary care, but also allowing communication between both primary care and secondary care to facilitate, improve our working and to see how we can do things better.
It's valuable, it's a great means of learning, developing our skills, our knowledge. At the end of the day, we want to give our residents the best possible care, and the only way we can do that is by getting proper training. In the middle of COVID, things were changing on a daily basis. You were trying to keep up with rules and regulations, and you were scratching your head and you're thinking, am I doing this right? Am I doing this wrong? Everything was very rapid, but in Echo, we were all going through the same kind of situations. It was just supportive to know that there was others going through exactly what I was going through and my colleagues were going through in the nursing home.
Echo has always been for me technology enhanced learning. It really is about communities of practice and bringing communities and people together to share their learning. It genuinely is true when they say everyone is a teacher and everyone is a learner. There hasn't been an Echo that I've been involved in where I haven't learned something, whether I'm facilitating or participating.
We had one of our GPs dial in for a patient who has had a very long-standing diagnosis of heart failure. So very poor pump function with the ejection fraction only around 15%. But they were last treated in the secondary care setting 8 years ago. But it turned out that patient was now only on what we would consider now standard of care. There are 4 separate pillars that are used in combination that are synergistic with each other, and he was only on 2 of them. Now, he remained symptomatic, but everybody had just accepted that that's just the way he was. But his GP, by hearing about our service, called in and said, well, look, is he on the best therapy? These are his blood test results, this is blood pressure, this is his heart rate. What should we do? And so we gave advice during a first clinic session with them, and then they dialed in a second time to give us an update. Through all that, we were able to get him on the 4 out of the 4 pillars, and then we rescanned his heart, and we were able to show that this man, whose pump function had previously been very, very poor, high risk for heart failure hospitalisation, high risk for sudden death, and we had normalised his pump function. I mean, I don't think there's any greater win than that.
I came across Echo when Max actually started it as a project and thought it was a clever initiative. It has kept people completely up to date. It has allowed respectful, open discussion and debate in a very non-judgmental way on many, many areas of difficulty for people working in the field. I think the cost benefit of Echo is far wider than those involved, because it is about the benefit in the quality of care given to patients. It's about maintaining professionals who think, who question, who look for answers, who don't just accept perhaps that things look bleak or nothing can be done or whatever, but are constantly questioning their own professionalism and their own activities to drive standards up. That benefit you can't measure in pound signs or euros or whatever currency you want to use, because actually it is much more profound than that. It's about the benefit to the human condition.
In healthcare, the importance of safe spaces for building trust, for sharing new evidence, for growth in understanding, and for the creation of new efficient ways of working are crucial if we are to respond effectively to the huge challenges we face of escalating demand and workforce weariness. Through the investment by the HSE in Project ECHO in Northern Ireland, patient and professional lives have been changed and new services developed. And our use of ECHO has been copied across the UK and beyond. ECHO has shown us, by working together, we have the most chance of making things better and maximising the skills and expertise of our teams. Together, we can make things better.
You may feel the worry of the world is resting on your shoulders. You may feel that any minute now it's gonna buckle at the knees. You may feel the worry of the night that comes to steal your sleep away. We're gonna let it sound, let it sound. It echoes around the world. It echoes around the world.